Yeah, Aaron Pollock, NICHD. I, I don't know. This question is probably just a restatement of questions that have come up, but I'm maybe going to try to get a little bit more maybe if people could comment on challenges to the following. I mean, one of the things that I've sort of always wondered what we can do is how to integrate data types and results from different types of trials, right? You know, either like an opportunistic study that's maybe prospective and pragmatic versus real world data, and then bringing in clinical trial data, right? They all have pros and cons to those kind of study designs. But you know, at the data level, I don't see them being combined a lot. You sort of get the results and then people talk about the differences between the results. What are the challenges, or are there things we can do that relate to harmonizing code books or thinking about how we can organize real world data? Or are there things that the real world data gurus would like to see clinical trialists incorporate that would make that interoperability possible?
I think I can make a comment if that's okay. I was going to say I'm guessing what Dr. Rosen was going to get at was that I think the goal of the code book is really to sort of start this process. I think that the idea is to have this code book where the data sets and the variables and even like the category of the different variables are sort of neatly organized and standardized, and the goal being that investigators can look at the code book and see exactly what's in different studies and be able to sort of better harmonize the results of different studies, and be able to utilize them. I think there would be, of course, numerous considerations if you're combining data from different studies, but I think the making the code book required was sort of the first big piece in trying to standardize the data across studies, which is challenging to do if you're a submitter trying to organize everything on the back end. But I think if we can start using the code book, the structure and format of it to sort of plan study variables in advance, then we'll be a lot more on the same page when it comes to looking at standardized data across studies later.
And I'm sorry for the IT issues. This has been a pattern. I would completely agree with that. And it's one thing that we are considering, and I'd love your feedback on this, is sharing the code books earlier for studies as they are collecting data to see what standards others are using for similar research, so that researchers can start using similar standards for harmonization down the road. And as I was saying before I lost you, is that harmonization of data that's already been collected and shared is an incredibly significant challenge. It's a research challenge, and it is out of scope for a repository, but not to say it's impossible. There are a number of folks working on this, and of course, new tools and technologies making that possible, but it is something that we really do want to do upstream. And so that's what I mentioned, the update. So Elizabeth, you haven't seen the updated code book yet. It's coming out shortly, but it'll allow you to include that persistent identifier for a variable level standard, so that others can find the exact version of the standard that you and others have utilized in the data collection process. So this just gets to use published standards as much as possible. And if they don't exist, work with your community to identify the need and start publishing them, and validating and publishing them in standard repositories as well, because those do exist.
I will add a comment. So my center is part of the U54 network, the Maternal Health Research Center of Excellence. And right now we're working with the data hub on harmonization process. So we're going through the Delphi process of selecting variables that will be used across the centers. And I wonder if going forward, this can be used for all NICHD funded studies with birding people.
You know, I think, Dr. Pollock, one thing you mentioned that I think is really relevant to the discussions that we've had already this afternoon is combining research data with real world evidence data. And as the real world evidence folks are getting together, and how do we standardize things from medical records, having this type of a forum where we have all of the people in the room who need to have those conversations so that we can harmonize that, because it does us no good on the research side to harmonize our code books if they make no sense when you're trying to combine it with real world evidence data. Because I think in the end, there has to be a way for us to get these data together to understand if different settings mean different things. If things outside of the research setting are so vastly different, but if we're not speaking the same language in terms of outcomes and exposures, we can't ever make those statements.
Yeah, I mean, is there an equivalent for code books for real-world data studies? Like, is that something that's required for those kind of studies at all?
I mean, I would defer to the people in the previous panel, but I think that's where things like OMOP and all those other conglomerations of letters that I don't understand get thrown around, is in trying to standardize what gets characterized up.
Mm-hmm.
Well, I'm not sure, because when you say real world data, it could be a number of different sources. But if we're talking about data sourced from electronic health records, there are health IT standards that are in use for the administrative data. And those are widely published and available. And they can be shared in Dash. You can just indicate at the variable level in the code book that you've utilized a LOINC code or the RX norm codes data, other standards utilized in the electronic health records. But maybe somebody from the real world data panel wants to talk about other data sources. Just saying, in general, you can annotate your data and submit it into Dash in the exact same way. There's no reason why you can't utilize the same data collection standards. They're just not always appropriate between a clinical setting and another setting where data are collected specifically for research purposes.
This is about the CDEs. So I found very helpful the NICHD had REDCap CDEs related to COVID-19 and pregnancy. I was not able to find other pregnancy-specific CDEs, just like basic, pregnancy history or medical comorbidities or pregnancy outcomes. I think that'd be really helpful to have things that sort of are universally collected across clinical trials and pregnancy, but everyone may be collecting slightly different information. And so if that's available, if you could share where to find it. I searched the CDE page just with the search function. I couldn't find it. And then my second question is, and I think Dr. Palatnik kind of brushed on this, I think having core outcomes for kind of high priority topics would be helpful, whether it's diabetes and pregnancy, hypertension and pregnancy, prematurity, again, just so everyone knows whatever they may specifically be collecting in their research, but some core outcomes are always collected for the purpose of combining data.
I would second that. And I will put a plug out for the COMET initiative, because that's been trying to do that in obstetric trials so that people do start to measure things in the same way and call things the same thing. So if you're designing a clinical trial like I am right now, and I'm taking all these notes about the data standards, you should go to COMET and see if there's a core outcome set already done.
Yes, so I'm going to take a little bit of a different approach to my question. And we have a number of early career investigators and trainees here. And Dr. Payne did a great job of walking through what needs to be put into the file system for Dash to start a study. And I think, you say you've done 7 or 8 of these or 20 of these, and so you've gotten familiar with them over the years. But from an early career investigator, or maybe someone who's putting in their first RO1 or working on their first clinical study, how long and what resources are needed to be able to update the Dash site for them? So, I think that's one of the things we need to get used to incorporating is data management team to allow for this as well.
Yeah, so if I was an investigator doing my first submission, I think so the team that I work with includes a SAS programmer, first of all, to sort of go through the redaction process in our SAS files and CSV files. So that's sort of the data set preparation side would be, utilizing programming support. And then for the document redaction piece, we have a medical writer who assists on that side. And then let's see. So that's kind of the preparation of documents and data sets piece. And then in terms of preparing the different text fields that you're going to be submitting, I typically do that myself. I think that's something an investigator can do, kind of just going through the files, the reports that they have, and the reports that they've written. It does take a little while, especially if it's your first attempt using the DASH system and the DPT tool. I think so. If you just sort of know that going through, you're just going to be sort of working through the process for the first time, getting comfortable with it, then I think that helps to sort of go in understanding, that this might take a little while to get your text ready and your documents and data sets ready. But I think once you've done it once, then you get more comfortable with it, of course. And if you're someone who's going to be doing numerous submissions, the more you can automate processes, of course, the easier it's going to be. So I think, after a while, I got to the point where I could do it relatively quickly. It still takes some hours to sort of prepare the text fields and things. But yeah, so I guess I would say, an investigator could do most of the submission themselves. I might utilize, medical writing and programming support for preparing documents.
And I think on the other end, with trainees who want to utilize the data, I think as Dr. Palatnik said, get them to download the code book. Now, code books are not small. I printed off in a fit of ignorance the one from Newman to Be, which was tiny type and I think 35 pages. So it's a lot of stuff, but print them out and look at what you've got. And that's how you can then generate your questions.
I would also add codebook plus previous papers published for this data set. So you can see like the tables, how they use the variables, very helpful using both.
I'll get to you, Lang, for the last question here in just a second, but I had a quick question for Dr. Rosen, I think. Is there, speaking to that last point, is there a place on DASH where all of the papers that people have published using DASH, are they listed within some page underneath that particular study? Like all of the Consortium of Safe Labor papers, the dozens of papers, is it listed there so that you don't reinvent the wheel?
Yes, right now it's on the study page themselves, and because they come through with the annual report, it's updated per user or per request annually. And so we do want to make that more current by linking to various persistent IDs, and that's something that's on the list. Your point about the code book is interesting in that it sounds like you were downloading a 35-page PDF, and that's not the way that now we have a required code book that's machine readable. It's CSV, an Excel file, and so that's a move in the right direction there. We also are strongly encouraging identification of CDEs in the code book so that we can in the future start listing them in the code book template, so you can kind of pick and choose. So these are some of the ideas that we have moving forward to make it easier for both submitters and requesters. But just one other thing, Elizabeth made a comment, and I want to just emphasize this early and often. I really like what you had said about reaching out and talking to the curator right away. Once you've gotten your award, get started. Ask about the code book, ask about standards. Our curation team talks to researchers submitting, and so they see a lot of what other researchers in your area are doing, and they can put you in touch or provide some knowledge to you.
Yeah, I would echo that again. I feel like the DASH team has helped me so much with, if you just reach out with questions or even for a training or discussion of how to do different things. They're really a nice group of people who are very helpful.
All right. So it's not really a question. I think it's kind of a response, comments of previous questions. 3 points. Number one, as Erin asked, what will be opportunities for integrating trial data and the real world evidence data? Actually, one possibility is really figured out how do we design a trial where using real world evidence as control arm, which we talked about in the previous session, which is really valuable way to do it. There are trials that do it right now. Okay, so there are publications on that domain. It's very powerful actually application of real world evidence. So that's one thing I want to point it out. Number two is about the integration of the clinical trial data and the EHR data. There are two levels of integration. Number one is really at the term level. I noticed that that Dash using MedDraw as dictionaries to capture diverse events, right? But in the EHR data, they don't use MedDraw. They're using ICD-9 codes or the other words. So the number one thing is really trying, how do we match the MedDraw versus ICD-9 or ICD-10? So that's really at the term level data integration. The next level data integration is on the disease phenotype level. For example, how do we define the diabetes, how do we define the hypertension? There's a whole bunch of ICD-9 codes all together to do it. So that has to be figured out as well. So I think those two levels of data integration has to happen in order to make it happen. Okay, just trying to give the example how things can look like when you're trying to do the data integration. Number three, I want to point out education is a big deal. I think a lot of clinical pharmacology fellows, physician fellows, they're really well trained in clinical domain. But I feel many of them are not necessarily very well trained in informatics. Means that if you give them the data, they may not be able to manipulate data, doing very simple manipulation. I think that's something we need to think about. How do we train, the training a bit more with informatics skill, then can give them data, can run with it. Instead has to rely on a lot of informatician to help them, because this is kind of a probably more efficient way to pursue the research. Maybe you can touch base tomorrow as well in terms of how do we think about next generation of clinical pharmacologist training. I think this is a really good way to do it, and we have a lot of resources here. All right, I'll stop here.